All right, so in this chapter, we're going to talk about heart failure and circulatory shock. So to define heart failure, this is going to be your heart's inability to keep up with the metabolic needs of the rest of your tissues. So we have some compensatory mechanisms of heart failure, and they're all aimed at increasing cardiac output, right? Because if you increase cardiac output, then you can basically help perfuse more of your body's tissues and reverse that heart failure. So that's going to involve several different mechanisms here. And for one, it's going to involve your kidneys. So what we find then is that if your cardiac output is low, you're going to see a decrease in kidney blood flow, which means your kidneys are less likely to filter blood. They're going to retain more sodium and water because they're not filtering as much, which means you maintain or increase your vascular volume. And if your blood volume is greater, you're going to have more venous return to the heart. And when you increase venous return to the heart, it causes an increase in stretch of heart muscle. And if y'all remember going back to anatomy and physiology, we talked about how the Frank-Starling mechanism allowed for cardiac muscle to contract more strongly when it's stretched more. So if you can increase more blood flow or venous return to the heart, then it's stretched more and it can contract more strongly, which means you increase stroke volume and therefore increase cardiac output. That makes sense. Now, we can also have some sympathetic reflexes as well. For instance, if your blood pressure starts to decrease, we see that we're going to have an increase in heart rate and an increase in heart muscle contractility, which is also going to increase stroke volume and therefore increase cardiac output. Now, the sympathetic reflexes can also act on the blood vessels of your body. And what this can do then is actually allow for a little bit of a increase in vascular resistance, which is going to increase blood pressure. And what's possible as well is that if there's a lot of resistance or afterload, it could be more difficult for your heart to eject that blood. And so your vascular tone is going to basically be modified in such a way that you can maintain blood pressure, but also allow for adequate blood flow. So you wouldn't want too much vasoconstriction because that could actually increase afterload too much and put a lot of stress on the heart, but also decrease blood flow. So you're going to find that the vascular tone, or sort of its steady state, is going to be adequately matched at the point at which your blood pressure is normal and blood flow will be normal as well. Now, the kidneys play a role, again, in the sense that if you have a decrease in blood flow to the kidneys, they're not going to filter as much. And we talked about how when there's a lower glomerular filtration rate, the cells of your kidney release this hormone called renin, and that's going to activate this RAAS, the renin-angiotensin-aldosterone mechanism. Now that leads to the production of angiotensin II, which can vasoconstrict, but angiotensin II also causes your adrenal cortex to release aldosterone, and aldosterone allows your kidneys to retain more sodium and water, which again increases vascular volume, which allows you to have a greater blood volume and therefore increased venous return, and that's going to allow for greater stretch of your cardiac muscle, and again that's going to increase cardiac output by increasing stroke volume. So what's interesting here is that you see this interconnected network of lots of different reflexes that involve both your heart, your blood vessels, and your kidneys. So in terms of the different types of heart failure, it could be systolic or diastolic heart failure. If it's systolic heart failure, we're talking about how it's an inability of your heart muscle to produce a strong enough contraction to force enough blood out of your heart. If it's diastolic heart failure, we're saying that your heart muscle isn't able to relax as well, and in that sense it can't fill up with as much blood. So if your ventricular end diastolic volume is decreased, then that's going to decrease stroke volume as well. Now there's different types of heart failure in terms of their side. You can have right-sided or left-sided heart failure. Right-sided heart failure would lead to a backup of blood in the systemic circuit, like the rest of your systemic veins, rather. And then left-sided heart failure is going to lead to a backup of blood into the lungs. So there's high output versus low output failure. And if it's high output failure, we're saying here that the heart is able to pump out blood, but not enough still to meet the metabolic needs of your tissues. And if it's low output failure, we're saying your cardiac output is still low, and again, also not able to meet the metabolic needs of your tissues. So in terms of the manifestations of heart failure, also ultimately they can come from the effects of impaired pumping, whether that's due to impaired filling or impaired contraction. Either way, the pump's not working properly. And so we understood how this has effects on your RAAS, the renin-angiotensin-aldosterone pathway, because if you decrease renal blood flow, it's going to cause the release of renin, which acts to increase blood pressure. And there's also going to be sympathetic reflexes, because once the baroreceptors have decreased stretch within the carotid bodies of your, right at the place where your internal and external carotid arteries split, this is going to lead to a sympathetic reflex that causes an increase in heart rate, an increase in heart muscle contractility, and stimulation of the RAAS. So if we look at in terms of the right-sided heart versus left-sided heart failure, let's talk about what happens if you have right ventricular failure. We know that the right ventricle receives blood from the systemic veins, and then it pumps blood out through the pulmonary trunk towards your lungs. So if this if the right side of the heart's failing to pump blood along, we call this right ventricular failure, you're going to see congestion of blood in the peripheral veins or peripheral tissues. Now, for one, this can lead to edema and ascites. Edema is just going to be sort of a swelling of fluid or fluid accumulation within the systemic tissues. And then ascites is the same thing, but for the hepatic portal circulation for your digestive organs. So in either way, you're going to see fluid retention due to congestion of venous blood. Now, liver congestion also can occur as well, and this is going to be associated with the signs related to impaired liver function. So you're going to see things like a decrease in the synthesis of clotting factors and processing of nutrients and all those functions of the liver. Now for GI tract congestion, what this can lead to as well is things like anorexia, GI distress, and even weight loss, because if there's an adequate blood flow through your GI organs, you're not going to be able to deliver nutrients to the rest of your body's tissues very well. That's right-sided heart failure. For the left side, what we find is we know the left ventricle receives blood from your lungs via the pulmonary veins, and then the left ventricle pumps blood out through the aorta towards your systemic tissues. So you're going to see a decrease in cardiac output to the systemic tissues and a congestion of blood towards the lungs. So you're going to have pulmonary congestion, which can lead to pulmonary edema. And so pulmonary edema is going to be a swelling of fluid within, basically the lung tissue. Some of that fluid can actually make it into the air-filled spaces of your lungs, which then could actually cause you to cough frothy sputum. Also have, difficulty breathing at night, and also difficulty breathing while laying down. Now, in terms of impaired gas exchange, this is going to come from the fact that you're increasing the respiratory membrane thickness because of this accumulation of fluid, and we know that diffusion is going to occur more slowly, so this is going to cause things like cyanosis and hypoxia, and this is all due to that pulmonary congestion. Now, in terms of the decrease in cardiac output towards the rest of your body, this is going to be associated with activity intolerance and then signs of decreased tissue perfusion, like distal ischemia, coldness in the distal extremities, and an inability of your heart to basically supply your tissues with enough nutrients to function properly. So, in terms of left-sided heart failure, remember we have diastolic and systolic failures. If it's a diastolic left-sided heart failure, we're saying the left ventricle doesn't accept enough blood from the lungs. And this can come from a variety of sort of functions. It could be due to the fact that the left ventricle is scarred and it might not be more compliant. And if it can't fill with blood properly, then we're going to find that it can't really pump that much blood either. And then systolic failure would be the left ventricle can't force that blood well to the rest of your body. And this could be associated with conditions like, ischemia of the heart muscle tissue on the left side. It could come from certain toxins or infection. There's a variety of things that can lead to a decrease in cardiac muscle contractility. Now, blood's going to end up backing up into the lungs and eventually also backing up towards the right side of your heart and the other side of your body. So what's interesting here then is that left-sided heart failure could lead to right-sided heart failure because it's all an interconnected system. But ultimately the lungs are going to fill with fluid here because of basically blood's backing up towards the lungs. Now, with right-sided heart failure, its diastolic dysfunction is going to come from the fact that the right ventricle might not be able to accept enough blood from the body. And this is going to be due to inefficient relaxation or maybe stiffening of the ventricular muscle. And then the systolic failure here is going to be the right ventricular muscle can't force that blood to the lungs properly. So what's going to happen here is you're going to see a decrease in cardiac output to the lungs, but also a backing up of blood towards the rest of your body, and essentially causing congestion of blood into the systemic veins. So what's interesting here then is that you're going to see a decrease in blood flow to the lungs, which is also going to cause the left side of your heart to have to work more strongly. And so what's interesting is that right-sided heart failure can also lead to left-sided heart failure. Now, because the left side of the heart pumps blood to the rest of the body, what's interesting then is if you have right-sided heart failure and blood's backing up in the systemic veins, that can actually make it more difficult for the left side of your heart to pump blood out through arteries because blood's backing up into those systemic tissues. So again, right-sided heart failure can also lead to the left. But ultimately what we find then is that the body fills up with blood. So you're going to see distension of the veins of your body, sort of swelling of those veins. And then also your lungs aren't going to be properly oxygenated. So you're going to see a decrease in O2 levels. So pulmonary edema is sort of that swelling we talked about. And this is going to come from an accumulation of fluid within the tissue itself. Now, capillary fluid ends up being forced into the alveoli through an increase in capillary hydrostatic pressure. If you guys remember going back to the blood vessel chapter, we talked about how an increase in capillary hydrostatic pressure can force more blood plasma across the capillary wall into the interstitial fluid. And so in this case, we're going to find that is that the alveoli can start to accumulate a lot of fluid. The lung becomes more stiff. It's harder to inhale because there's more resistance. You're going to see less gas exchange in the alveoli because of a thickened membrane. It's going to be identifiable based on crackles, and crackles kind of sounds like a sort of a popping sound. It kind of sounds like pop rocks in your mouth, but it's a sound that's coming from deep in the lungs where the alveoli are basically popping open. It's making a noise. And you might find that someone actually can have a productive cough with frothy pink sputum. Now, what we find then here is that hemoglobin is not going to be completely oxygenated, again, due to difficulty in gas exchange. And so this can actually lead to hypoxia and cyanosis. Now, the question here says true or false. The characteristic pink sputum produced in pulmonary edema is tinged with blood. Would that be true or false? And that's absolutely true. This is going to be very extreme pulmonary edema, and it's where you have so much blood pressure, it's such a high capillary hydrostatic pressure, that some of the capillary walls are being ruptured due to that increase in pressure, and that some blood is being forced across the capillary wall into the alveolar space, so that the sputum that's kind of pink is actually tinged with some red blood cells, which is obviously abnormal. Now, this next scenario here says Mr. M has heart failure, complains of severe shortness of breath, and has fluid in his lungs. He has tachycardia and increased diastolic blood pressure, and has pale, moist skin, and says he feels pretty weak, dizzy, and anxious. So the question here says, which of these signs and symptoms are due to a decrease in renal blood flow, which are due to sympathetic nervous system, and which of his heart do you think is failing? So in terms of a decrease in renal blood flow, this is ultimately going to lead to the essentially the feelings of things like being weak, as well as an increase in diastolic blood pressure. Now, in terms of feeling anxious, this can actually come from an accumulation of wastes in blood. So what's fascinating then is that a lot of the uric acid and other nitrogenous waste that the kidneys would normally handle can actually have effects on your psychology and actually can change sort of your conscious state, and you can feel more anxious as a result of that. Now, in terms of the sympathetic nervous system here, that's going to be associated with more like the moist skin, your tachycardia, an increase in diastolic blood pressure as well. And the reason for this is that the tachycardia results as a consequence of a sympathetic reflex to try to get your blood pressure back up, or to try to oxygenate your tissues better. You're going to see an increase in diastolic blood pressure as well, due to basically a congestion of blood in the systemic vessels. Diastolic blood pressure is going to be higher as well through severe sympathetic vasoconstriction, and that's your sympathetic nervous system's attempt to try to keep blood pressure up. And then which side of the heart do you think is failing? Well, in terms of these particular symptoms, when we talk about a fluid accumulation in the lungs, that's more commonly associated with left-sided heart failure directly. Because the fact that the left side of the heart receives blood from the lungs, if it's failing to effectively pump blood along, then blood's going to back up in lung tissue, leading to pulmonary congestion. Now, technically, right-sided heart failure can also lead to pulmonary congestion, but in a very indirect way, and it's less common as a result. So shock is similar to heart failure. However, shock results from a dramatic decrease in blood pressure. Now, shock isn't necessarily always due to heart failure, but it can be caused by heart failure as well. So, for instance, cardiogenic shock, which is going to be a form of shock that's caused by, heart failure. If the heart can't pump blood along, your blood pressure is going to be so low that you can't adequately have enough blood flow to supply your body's tissues with nutrients. And so that would be cardiogenic shock. Now, other forms of shock, though, can be caused by things like low blood volume. They can be due to obstructions, or it can actually be due to massive vasodilation. And in that regard, we call that distributive shock. So if we have a loss of a lot of intravascular volume, this could be from like blood loss or severe dehydration, we call this hypovolemic shock, where your blood volume is so low that you have poor venous return to the heart, so then you have poor cardiac output. And again, that's going to lead to decrease in blood pressure, which in this regard is going to be shock. Now, obstructive shock could be due to mechanical obstructions of different types of emboli. Now, emboli can be made of things like blood clots, they can be made of fat, amniotic fluid, even cancerous masses and air, but all of those can actually obstruct blood vessels and lead to a decrease in blood pressure and ultimately poor perfusion of different parts of your body. So what this slide is showing here is essentially, imagine a circumstance where, let's say, the pulmonary trunk was blocked by a large blood clot. Well, you're going to have poor circulation to the lungs, and then ultimately poor circulation to the left side of the heart and a decrease in blood pressure. Now, distributive shock results from massive vasodilation. And this could come from things like infection or autoimmunity, but ultimately it's going to be due to a massive vasodilation or even actually brain damage. But when your blood vessels vasodilate, then blood's going to flow to tissues in a very ineffective way, and blood will be distributed in ways that cause your blood pressure to decrease dramatically. But remember, blood only flows from high to low pressure. So if you have massive vasodilation, your blood pressure drops out, blood stops flowing. So this scenario here says Mr. M was injured in a motorcycle accident. And on arrival at the hospital, he presented with bleeding from his right leg, restlessness, pallor, sweating, elevated heart rate, weak pulse, rapid breathing, lack of bowel sounds. Blood pressure was slightly elevated here. So the question here says, what has happened to this patient's stroke volume, cardiac output, and sympathetic nervous system? Well, this patient's stroke volume may have increased. However, due to the fact that their heart rate's elevated, it's more likely that their stroke volume actually has decreased, and that their heart rate is increasing to compensate for the decrease in stroke volume. And if your heart rate increases enough, this could actually increase blood pressure a little bit. This would be one of the compensatory mechanisms of shock. But in this gentleman's case, what we find then is actually it's probably due to blood loss. So from excessive blood loss, you end up undergoing hypovolemic shock, where you have poor venous return to the heart, so that your heart rate has to increase just to try to keep your blood pressure up. Now, the cardiac output may have increased, which would explain the increase in blood pressure. But remember, blood pressure can also be increased through vasoconstriction, which would be activation by your sympathetic nervous system. So it's possible that the cardiac output may have actually decreased, but the blood pressure could be slightly elevated due to vasoconstriction in the peripheral tissues. And these are all sort of compensatory mechanisms of shock. So with shock, you're going to see all of these sort of signs and symptoms associated with the compensatory mechanisms, right? Where in this case we see blood loss, but if you have restlessness, pallor, and sweating, as well as elevated heart rate, this is going to be due to an increase in sympathetic nervous system activity, as well as rapid breathing, again from an increase in sympathetic activity. And then if a lack of bowel sounds would be more consistent with an increase in sympathetic nervous system activity as well, because your sympathetic nervous system inhibits gastric activities, or sort of digestive activities rather. And then the blood pressure being elevated again could be part of the sympathetic compensatory response. This next scenario here says, although he was given 6 units of blood, Mr. M got worse. So 6 units of blood would be like 6 liters of blood. And so that's quite a bit of blood. Now, he became lethargic, his blood pressure began to fall, and he still had no bowel sounds or urine production. The intern ordered epinephrine, and Mr. M's blood pressure increased. Why is this? Well, his blood pressure may have begun to fall due to maybe a transfusion reaction, where his immune system was activated and started to respond against that donor blood. That could have led to massive vasodilation, causing the blood pressure to fall. But with epinephrine, that's a vasoconstrictor, and the vasoconstriction here can actually increase blood pressure. And then later here he said this, you overhear the resident telling the intern that it was not the best treatment. Why not, if it raised Mr. M's blood pressure? Well, epinephrine is going to put a lot of stress on the heart because it's going to cause the heart muscle to try to work more strongly, and it's going to also cause your heart rate to increase. Now, if the heart's already been stressed because of shock, a better treatment would be another vasoconstrictor that doesn't have an effect directly on the heart. Something like angiotensin II, or a different type of vasoconstrictor. So Mr. M's blood pressure went up a bit, and he's been moved out of the ICU. This next question says, his chart says you should do a 24-hour urine collection, and why might that be? Well, we learned earlier how one of the consequences of shock is actually kidney damage. Because remember, what we talked about then is that if shock leads to poor perfusion of peripheral tissues, if the kidneys aren't getting decent blood flow for an extended period of time, he may have actually had renal failure from that lack of blood flow to the kidneys for however how much time his blood pressure and blood flow were low. So we want to do a 24-hour urine collection to make sure that his kidneys are now functioning normally now that this blood pressure has been stabilized and normalized. So this next scenario here says Mr. M appears to be improving. He sleeps quite a lot, but his blood pressure has remained stable. He had a little urine production, and he did not eat his supper. Checking on him in the evening, you notice that he is slightly flushed, his respiration rate is a little high, and his temperature is elevated. So this next question here says, what's happening to his peripheral resistance? Well, remember, peripheral resistance is going to correlate with blood pressure. Now, remember, the blood pressure here has remained pretty stable, and he had a little bit of urine production, so his urine production hasn't really increased a whole lot. So the peripheral resistance may have actually, remained fairly stable, considering his blood pressure is pretty stable. And then, what do you expect his heart rate to be like? Well, his heart rate could be increased in order to maintain normal blood pressure. It really just depends on how much peripheral resistance is going on. Now, this next part here says, checking on the evening, you notice that he is slightly flushed, his respiration rate's a little high, and his temperature is elevated. Now, if these are occurring, this is going to be sort of consistent with an immune reaction, right? When you start talking about being slightly flushed through vasodilation, having a higher respiration rate due to possibly even lysis of some red blood cells, and then having a higher temperature also is a systemic manifestation of inflammation. And so what might actually be going on here, based on these signs and symptoms, it's possible that he's actually having vasodilation, which is decreasing his peripheral resistance. That would actually explain the low urine production, but then his heart rate could be high to try to compensate for that sort of decrease in peripheral resistance. Because remember, the equation for blood pressure is cardiac output times total peripheral resistance. So if you can increase heart rate to try to increase cardiac output, it could compensate for decreases in peripheral resistance to maintain normal blood pressure. So in terms of going into the specific types of shock, this first one here is cardiogenic. So remember, cardiogenic shock is a form of shock where the heart fails to pump blood adequately. This results from a decrease in cardiac output, which ultimately causes lower blood pressure. And the sympathetic nervous system responds through vasoconstriction and an increase in resistance to blood flow. Now, this actually puts an increase in pressure and work on the heart muscle itself, which actually contributes to further heart failure. So although your sympathetic nervous system is trying to compensate for the low blood pressure, if your heart's already failing, having a higher diastolic pressure due to vasoconstriction is actually going to cause the heart to have to work even more strongly to try to keep blood moving. So this is sort of a negative feedback here with cardiogenic shock. Now, distributive shock, which we also call vasodilatory shock, is actually caused when blood vessels vasodilate. And we talked about there's different ways that blood vessels can vasodilate, or different reasons for that. But it can actually be caused by inflammation, and that inflammation may be due to infection. And this is actually going to be where blood flow decreases because of massive vasodilation. As a result, you see less blood is actually returned to the heart, and therefore less blood is circulated throughout the body. Now we call this distributive shock because what we're saying then is that blood is inadequately or inefficiently distributed throughout the blood vessels of your body. You might want to increase blood flow to your heart, but instead, if you have massive vasodilation, you could see an increase in blood flow to like your skin or muscles or digestive organs, where it may not be as appropriate to be in that moment in time. Now, some of the causes of distributive shock could be due to neurogenic shock. And so with neurogenic shock, this is actually due to brain damage, where if your sympathetic nervous system centers of your medulla oblongata are damaged, then you can see then that the blood vessels of your body will actually lose their sympathetic tone, and they can just have massive vasodilation. And so that would be from brain or spine injury. Now, it could also be from excessive anesthetic administration. So if someone's under too much anesthesia, that can actually inhibit neurons in the brain too much, and that ultimately that excessive inhibition could also cause vasodilation through loss of sympathetic tone. Insulin shock would be where you administer too much insulin, their blood sugar levels fall so much that their neurons can't have adequate metabolism to function properly. And again, your sympathetic tone is going to shut down, causing massive vasodilation. But it could also be emotional, which is fascinating. Now, in terms of the vasodilator substances in blood, it could be due to anaphylactic shock as a consequence of type 1 hypersensitivity through like the massive release of like histamines, and those histamines can cause pretty dramatic vasodilation. Or it could be from inflammation due to infection, like sepsis. So septic shock is also considered distributive shock because if someone has an infection in the blood and they get massive inflammatory response, you remember histamine is also released here, and that's going to cause vasodilation and also could be so dramatic that it causes distributive shock. So just to summarize this, remember there's three major causes of distributive shock. We have neurogenic, we have type 1 hypersensitivity, and inflammatory responses due to sepsis. Now we can also find here that vessels can get damaged from severe hypovolemia as well. This next question is actually what type of shock is caused by low blood volume? Is it cardiogenic, hypovolemic, distributive, or septic? Well, we know it's hypovolemic, right? Hypo means low, volemia means blood volume. So hypovolemic shock occurs when a patient has either lost blood due to trauma, surgery, or third space fluid loss, which could be like massive dehydration. So anaphylaxis is an interesting reaction here. It's considered a type 1 hypersensitivity, and it's where we have the release of so many inflammatory mediators like histamine, acetylcholine, the kinins, leukotrienes, and prostaglandins, which lead to vasodilation. And so that if you have massive vasodilation in response to these chemicals released during this hypersensitivity immune response, then your peripheral resistance drops. And when peripheral resistance decreases, you're going to see a decrease in blood pressure. But remember, blood pressure, blood only flows from high to low pressure. So if there's not a pressure differential, then you're going to see inadequate blood flow. So what's weird then with anaphylactic shock is that blood just starts to pool in different areas of the body, like the skin or internal organs. Now for acetylcholine, kinins, and leukotrienes, these can also lead to bronchoconstriction, right? And so what's interesting then here with anaphylactic shock is that not only does it decrease blood pressure, but it can also cause an increase in respiratory distress through bronchoconstriction. And so when the bronchioles constrict, this increases resistance along your airway, which actually decreases airflow. So it's like a double whammy here. You're having a decrease in blood pressure and a decrease in airflow. And so that decrease in airflow actually leads to poor gas exchange. So this is going to lead to hypoxia and all the problems that are associated with that. Now, in terms of septic shock, remember this is also a subtype of distributive shock. This is going to be due to infection, And so inflammatory mediators are released as a consequence of that infection, things like interleukins, tumor necrosis factor, even histamine. Now, this can actually cause vasodilation, but it also can cause systemic signs of inflammation, things like fever, increased respiration, respiratory alkalosis, and warm flush skin. And so this is an important distinction then between other types of shock, because if someone has fever, but you suspect they're in shock, that's going to be more consistent with sepsis, or at least severe sepsis, because that's going to be more of a systemic manifestation of infection and inflammation. Now, it can also activate other pathways like complement, fibrinolysis, as well as coagulation pathways. So this can also lead to sort of odd sequelae like disseminated intravascular coagulation and even thrombi and emboli that can result from these blood clots that are accumulating in the bloodstream as a consequence of activating these pathways. So with septic shock, we see that microorganisms could enter the bloodstream. And so once in the bloodstream, it can lead to basically an inflammatory immune response that leads to the release of inflammatory mediators like interleukins. And these actually have an effect on your brain because it's going to increase basically body temperature to make it less hospitable for these microorganisms. And what we find then is that severe sepsis can lead to things like hypotension because of massive vasodilation, hypoxemia because of bronchoconstriction, oliguria, which basically means a decrease in urine output, metabolic acidosis because of a release of lots of lactic acid from hypoxic tissues, and then things like thrombocytopenia from the depletion of clotting factors and platelets, and all of these are manifestations of septic shock. Now, septic shock, causes vasodilation, which decreases resistance, decreases blood pressure. That's what's going to really lead to the shock itself. Now, unfortunately, septic shock has a 40% mortality rate with treatment. Now, inflammatory mediators can also increase the metabolic rate of tissues. So even if you're already having bronchoconstriction and having decrease in air flow, but also a decrease in respiration across your lung membranes, what's interesting though is that these inflammatory mediators that increase the metabolic rate of tissues are going to accelerate the loss of oxygen from your body. So it actually makes the problem worse here. Now, this discussion here says, why is septic shock called distributive shock? Why don't we put this in its own sort of subcategory of let's say infection-related shock? Well, what we find though is that in the later phases of septic shock, blood volume decreases. And so which part of the inflammatory process could explain this? What's kind of fascinating here then is that through massive vasodilation, blood's going to get shunted to kind of odd locations, like your skin, muscles, maybe even some internal organs, and it's going to pool there, and that's why it's inadequately distributed. Now, in terms of losing blood volume, this could come from a lot of different sources. Unfortunately, though, with septic shock, you're going to see a decrease in blood pressure, which means you're going to see a decrease in urine output. So the fluid loss that's associated with septic shock, which can lead to a decrease in blood volume, is going to come from places like sweating because of the fever, as well as increase in ventilation so fluid loss can come from your respiratory system. So by breathing really heavily over a long period of time, you can lose a lot of water from your breath, and that can also decrease blood volume over time. So the question here says, which type of shock is the result of severe allergic reaction? Is it cardiogenic, obstructive, anaphylactic, or septic? Well, we know it's anaphylactic, right? And in fact, anaphylactic is actually a type 1 hypersensitivity. It causes distributive shock because it leads to massive vasodilation, and we know that this one's actually due to essentially, an immune reaction, and it's actually where you have, excessive, basically, immune response. So some of the complications of shock can be things like acute lung injury and respiratory distress because of a decrease in blood flow to the lungs and a massive bronchoconstriction. It can also lead to acute kidney injury, or AKI, and this is actually going to be due to a decrease in blood flow to the kidneys. And so what's interesting here then is that through a decrease in blood flow to the kidneys, they get less nutrients, which leads to essentially ischemia-related cell stress and possibly even necrosis. You can also find that there could be gastrointestinal complications, again through a decrease in blood flow to these organs. Disseminated intravascular coagulation can occur, especially if you're exposed to agglutinogens or other factors that can actually cause activation of your complement system and clotting cascade. And we can also get multiple organ dysfunction syndrome, where individuals die from essentially low blood pressure over time. Multiple organs to start shutting down. So the scenario here says a doctor has been called to treat in Mr. M, and has started off with fluid and antibiotics. You're warned to watch him carefully for any signs of respiratory distress, right? So why would blood pressure imbalances cause respiratory distress? Well, we talked about earlier how with right-sided and left-sided heart failure, you get a backup of blood in different circuits. Now, if you're treating this individual with fluid, then you're essentially going to be delivering a lot more fluid to the systemic veins first. But because the heart's been stressed for a period of time here, it needs to catch up with that excess in blood volume. And it's going to need to pump that blood out to the lungs. However, what can happen though is that because of this increase in blood volume in your systemic veins, it can put extra stress on the left side of your heart to pump out blood to the rest of your body, and that can actually lead to a backup of blood into the pulmonary circuit as well. Now, in terms of antibiotics, these are going to basically be aimed at treating the infection itself. So for acute respiratory distress syndrome, this can actually be a consequence of shock. And this occurs when exudate enters the alveoli and blocks gas exchange, which makes inhaling more difficult. This comes as a result of things like pulmonary congestion. In fact, what's also interesting here is that neutrophils can enter the alveoli. They can release inflammatory mediators and proteolytic enzymes that can actually cause long-term damage to your lung tissue as a consequence of shock. Now remember, acute kidney injury is also one of the systemic manifestations of shock, where renal vasoconstriction cuts off urine production, and this actually decreases blood flow to the kidneys, leading to acute renal failure and kidney injury. Now, continued vasoconstriction can cut off renal oxygen supply, causing the tubular cells of your nephrons to die. So what's fascinating here is that basically shock can actually lead to tubular necrosis. And you can find evidence of this in urine. Like if you're finding epithelial casts in someone's urine, that suggests that the epithelial cells of their kidney tubules have actually started to die, become necrotic. Now with disseminated intravascular coagulation, what's interesting here is that coagulation pathways are activated, and this can actually lead to clots in small vessels, causing microinfarcts and ischemia. But if this is massive enough, like especially with things like infection and type 1 hypersensitivity, platelets and clotting proteins can be used up, and this can lead to bleeding problems, where some individuals that have undergone shock and have had DIC, due to a depletion of clotting factors, they may be at risk for bleeding problems, like bleeding along the GI tract, along their gums, other kind of mucous membranes as well, and they might have difficulty forming clots adequately. Now, with multiple organ dysfunction syndrome, the most frequent cause of death is, sort of this non-coronary intensive care unit. Now, this is a consequence of shock, but essentially what happens is that you find that multiple organ systems shut down simultaneously. So, for instance, like if the kidneys would normally compensate for, your blood vessels or your heart, if their multiple organs are shutting down, then these compensatory mechanisms, you're losing your options in terms of keeping your blood pressure up. So unfortunately, with multiple organ dysfunction syndrome, mortality rates can vary from anywhere from 30 to 100%, depending on the condition. And the mechanisms of this aren't directly known, but it's just known that multiple organs shut down simultaneously. So it's a little more complex. So this next question here says, true or false? Treatment for acute respiratory distress syndrome, or ARDS, often includes breathing assistance using mechanical ventilation. Would that be true or false? Well, we see here that that's true, because alveoli are filled up with exudate, and blood that's leaked from the capillary causes the surface area for gas exchange to be decreased, so that most patients are going to require ventilatory support in order to increase their blood oxygen levels. And unfortunately, ARDS has a high mortality rate because it's difficult to ventilate these patients. Like if their lungs have filled up with a lot of fluid, and there's a lot of proteolytic enzymes that have destroyed their lung tissue and caused inflammation, they might just have really inefficient gas exchange. And if it's so bad that they can't keep up with the metabolic needs of their tissues, that can actually lead to death.